How do we diagnose a head injury? We can diagnose a head injury or suspect a head injury from the settings in vehicular accidents, whether road accidents, air accidents, rail accidents, or even water sport. We can suspect that a head injury might have occurred in a fall. Head injuries occur in war of the two distinct types. One is the bullet injuries or the missile injuries, and the other are the bomb injuries or the blast injuries. Head injuries can occur in sport, especially in combat sports like boxing or martial arts. It can also occur where accidental contact occurs, as in football. Cumulative multiple small brain injuries can result in the condition of chronic traumatic encephalopathy, also called the punch-drunk syndrome. Industrial settings are also a source of head injury. What are the mechanisms by which the brain gets injured in a head injury? You have impact injuries, where the head hits or is hit by an object. You have inertial injuries, where there is acceleration, deceleration forces causing neuroaxonal disruption. You have blast injuries, where the pressure wave is transmitted intracranially, resulting in damage to the neural structures. You have penetrating injuries, which can be simple, as in a bullet injury of low velocity, or it can be complex with cavitational forces, as in high velocity bullet injuries. A hypoxic component is often present in head injuries and adds to the cumulative insult, and it is usually underdiagnosed. Impact injuries are surface injuries. You can have lacerations of the scalp. The skull can be fractured. The convexity can be fractured, or the skull base can be fractured too. A skull fracture may be associated with an extradural hematoma. Skull base fractures may be associated with vascular or cranial nerve injuries. Impact produces injury to the surface of the brain. So you have primarily gray matter or neuronal injury. What is more classically seen are the bleeds because you can see them on imaging. You can have a traumatic subarachnoid hemorrhage, you can have a subdural hematoma, or you can have surface contusions. Inertial brain injuries are deep injuries. They often occur in conjunction with an impact injury. It can also occur without an impact. A counter-coup injury in an impact is also by inertial mechanisms. Inertial injuries classically produce injury to the axons, not to the neurons. The sites at which inertial ruptures or inertial injuries occur are the gray-white junction, adjacent to the corpus callosum, and in the brainstem. Axonal injuries can also be graded depending upon their severity. You can have a transient loss of conduction in axons. In fact, loss of consciousness in a head injury is because of an inertial stretch of the brainstem. A little more severe inertial stress can result in the production of axonal varicosities, which are associated with microskeletal injury of the axon. Most severe axonal injuries are complete axonal ruptures, which produce a histopathological picture of axonal retraction bulbs and the radiological picture of dot hemorrhages, which are because of a rupture of the microvasculature associated with the axon. The diagnosis of brain injury is not radiological, it is clinical. Cardinal features include a loss of consciousness. The duration of unconsciousness reflects the magnitude of the brain insult. There is a failure of memory registration of the event called event amnesia, just before the event called pre-traumatic amnesia, and after the event for a variable period of time called post-traumatic amnesia. Seizures can occur. Radiology gives valuable information about a head injury and about the further course of treatment to be continued. CT brain gives practically all the actionable information. MRI is usually unnecessary, but will give additional information in diffuse axonal injury, where there might be brainstem bleeds, small ones, which are not seen on CT. It can show you a good picture of spinal cord injury if surgery is being planned. Optic nerve injuries are better seen. CT is the workhorse. CT brain, or CT head rather, will show fractures, convexity, and skull base. Extradural hematomas outside the dura, usually associated with a skull fracture, are lenticular in shape. Subdural hematomas are crescentic shaped. Intracerebral hematomas are usually rounded or spheroidal. Contusions, which is blood into the brain, usually close to the surface, give a salt and pepper appearance. And traumatic subarachnoid hemorrhage can occur along the convexity or in the cisterns. Cerebral edema can be seen on a CT, reflected by the degree of brain shift in comparison with the thickness of a subdural hematoma. Brain shifts and brain herniations can be seen on a CT scan.